Good afternoon. It's good to be back with you. I'd started to mention pain in the earlier presentation. Let's take another look at pain in a little bit more detail and some strategies to reduce it. Here we go. Again, my same disclosures. As I mentioned, I'm an investigator in the cardiovascular inflammation reduction trial and in the ozanimod Crohn's disease trial. Let's begin with a definition of pain, but in regards to pain, this is something that most all of us have experienced at some time in our lives to varying degrees for varying lengths of time. I think it would be pretty accurate to say that all of us here knows what it feels like, but how is it defined in words? Well, according to the International Association for the Study of Pain, pain is an unpleasant sensory and an emotional experience that's associated with actual or potential tissue damage or described in terms of such damage. We know that there's a link between emotions and pain because patients who are experiencing chronic pain can be predisposed to the development of clinical depression, for example. Now, Dr. Clifford Wolf, who's a professor of neurology and neurobiology at Harvard Medical School, he's put out some classes of pain. One's nociceptive pain, the other is inflammatory pain and pathological pain. Let's take a closer look at nociceptive pain, which I'd also mentioned earlier. Nociceptive pain is caused by the stimulation of nociceptors. Now, a nociceptor is a type of receptor that's at the terminal end of a sensory neuron's axon that responds to damaging stimuli by sending possible threat signals to the brain, which are then perceived as pain. Nociceptors were discovered back in 1906. Now, in regards to nociceptive pain, there's some different classes. One is thermal. Perhaps maybe you needed to use the iron iron that was in your hotel room to iron your clothing that you just pulled out of the suitcase all wrinkled up. I know I did. If you were to have accidentally touched the iron with your finger, what you would have experienced would have been thermal nociceptive pain. If you had subsequently after that accidentally dropped the iron on your toe, what you would have felt then would have been mechanical nociceptive pain. If you have at the same time as you've been doing all of this, if you're also here with experiencing a chronic inflammatory disease, you may also be experiencing pain from that because of the chemicals that are released during inflammation, which cause chemical nociceptive pain. Now, in Derkham's disease, both the categories of mechanical nociceptive pain as well as chemical nociceptive pain can both be present. According to the National Organization for Rare Disorders, Derkham's disease is an extremely rare disorder, and one of the ways in which it causes pain is that the lipomas are thought to compress on nearby nerves, and that compression would be a type of mechanical pain. Derkham's disease and chemical pain, they kind of go together. Chemical pain is synonymous with inflammatory pain, and pain being a cardinal feature of inflammation. Cytokines, these are small secreted proteins which are released by cells that have a specific effect on the interactions and communications between cells. And there's significant evidence that certain cytokines are involved in the initiation and persistence of pathological pain by directly activated nociceptive sensory neurons. And certain inflammatory cytokines are involved in what's called inflammation-induced central sensitization. And by central, it means the brain, and can result in what's called, lead to the development of what's called allodynia. Now, one of the importance and significance of allodynia is that it can lead to the triggering, a person who has allodynia, they can experience the triggering of a pain response from stimuli that does not normally provoke pain. These pro-inflammatory cytokines, which you now may know, are produced predominantly by the activated macrophages and are involved in the upregulation of inflammatory reactions. And they're also involved, these inflammatory cytokines, in the development of both inflammatory and neuropathic pain. So now we see that it's possible that a patient with Derkham's disease could not only experience chemical nociceptive pain and mechanical pain by the compression of the nerves, but also neuropathic pain. There's abundant evidence that certain pro-inflammatory cytokines, such as interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha, are involved in this process of chemical nociceptive pain, with tumor necrosis factor alpha playing a well-established key role in pain models. IL-6, IL-1, TNF are active in the inflammatory process of Derkham's disease. Inflammation and nociceptive pain, they go hand in hand. And one of the things that the inflammation can do is set off a cascade of chemical reactions that literally prime the brain for the sensing of pain. Chronic inflammation does another thing in that it reinforces adaptive changes in the nervous system that can cause the sensation of pain to become exacerbated and inappropriate. So when chronic inflammation is present and these changes in the nervous system have developed, the person who's experiencing the pain can experience pain that is exacerbated and worse than what it would otherwise normally be. And for those patients who have a chronic inflammatory condition, such as Derkham's disease, these increased levels of inflammatory mediators at both not only the affected site, being the subcutaneous adipose tissue, but also as well as systemically, predisposes to them experiencing increased pain sensations. So the patients with Derkham's disease, they're already in a situation where they can experience increased pain compared to somebody who doesn't have the disease. There's significant evidence that certain pro-inflammatory cytokines may directly modulate various classes of neurons in both the sensory and in both the central and the peripheral nervous system. And in the peripheral nervous system in particular, it's been shown that abnormal spontaneous activity can be evoked from nociceptive neurons by the topical application of TNF to the peripheral axon. So basically what that means is you can take TNF alpha and you can actually apply it to these nociceptors on the neurons and stimulate a response. Now that I've talked about pain, the different classes, some of the pathophysiology behind pain, let's take a look at some strategies to management. Now, and the most optimal approach for treating chronic pain is to utilize lesser risk interventions first. And what are some examples of those? Well, for one is mind-body therapies such as meditation, biofeedback's another, acupuncture, electrical stimulation or E-stim. And in the case of Derkham's disease, which we've already heard about already, is manual lymphatic drainage or lymphatic massage. Patients with Derkham's disease can actually experience pain relief from this. Another is rapid cycling hypobaric pressure, and this has been shown in a 2010 pilot study to provide significant reductions in pain perception and intensity. And what this basically is touchless, rapidly cycled pneumatic hypobaric compressions, which are administered in a high-performance altitude simulator, and the mechanism of action being that it decreases tissue fluid congestion and improves oxygen saturation, which then can result in decreased pain in Derkham's disease. This is a photograph of one such high-performance altitude simulator. Some have said that looking at it from at least on the outside, may look a little bit like the cockpit of a jet fighter aircraft. Another low-risk low-risk strategy for treating chronic pain is what's called transcutaneous frequency rhythmic electrical modulation, otherwise known as FREM. And what this basically is a computer software generated sequence of modulated electrical stimulation, which varies automatically as far as pulse frequency, duration, and voltage amplitude. And it's been shown to be effective in treating chronic pain associated with diabetic neuropathy and other chronically painful conditions, including in Derkham's disease in at least one case report. Now, this is a photograph of what the FREM setup looks like. It's administered using multiple electrodes in various locations on the body. As you can tell, it looks somewhat like EKG electrodes. Now, another way of treating pain through the modulation of inflammation pathways is, and we've heard a little bit about this already today also, is dietary supplements. Curcumin's been mentioned, which is the active ingredient in turmeric. Another is capsaicin, Korean angelica. There are multiple examples of dietary supplements which can be beneficial in patients who have chronic inflammatory disease. Dietary modification is another. There are diets that have been suggested. One good one is the RAD diet. You may be familiar with that after breakfast this morning. Another good one is Dr. Gary Kaplan, who is the director of the Kaplan Center for Integrative Medicine. He has published some suggested rules for implementation of what he calls the ultimate anti-inflammatory diet. If you're interested in learning more about this and taking a closer look at some of these things, it's published on the internet, but he lists several suggestions as to what to include in the diet and to how to eat that can benefit in chronic inflammatory conditions. Which brings us to pharmacologic analgesic therapy. Now, as I'd mentioned, in the most optimal approach in treating chronic pain, these should be reserved for cases that don't respond to the lesser risk interventions. The application of the use of pharmaceuticals in the treatment of chronic pain is a popular option, although there can be associated adverse effects with the use of these drugs. The option as to what type of drug to select depends upon the type of pain that's being treated. Some of the different classes that are used are the non-opiates, the opiates, antidepressants, and anticonvulsants. Now, acetaminophen, that's one of the non-opiates. It was first marketed in 1955. It's commonly used. It's available over the counter. And when it's used appropriately, it's a safe medication. However, it can be extremely dangerous if taken in overdose. And overdose of acetaminophen is one of the leading causes of acute hepatic failure. If that overdose is not treated, it can lead to death, with the reversal agent being N-acetylcysteine. The non-steroidal drugs, they're commonly used as well in treating pain, both acute and chronic. They're available over the counter and as well as by prescription. Their use, they can be effective, and there's been some efficacy shown in treating the pain associated with Derkham's disease with these. However, they can also be associated with significant adverse effects such as gastrointestinal bleeding, peptic ulcer disease, edema, hypertension, kidney disease. Now, we'll add that the upper gastrointestinal adverse effects of this class of drugs can be mitigated somewhat by the addition of misoprostol. In fact, there's one prescription non-steroidal that's used that is a combination of an NSAID and misoprostol, which has a protective effect on the upper gastrointestinal tract. If misoprostol is going to be added in combination with a non-steroidal for upper GI protection, it's best that it not be prescribed in patients who are of childbearing potential because misoprostol is an abortifacient. Which brings us to the opiate analgesics. These are commonly prescribed for chronic pain. Patients with Derkham's disease, some have experienced pain relief, although there's somewhat limited efficacy in some. Again, like the non-steroidals, this class of drugs can have significant negative side effect profiles. If they're going to be prescribed for the use of chronic pain to a patient, it's best that it be done within the context of a pain management contract agreement with the patient that allows for random urine drug testing and that agreement be enforced. Any use or prescribing of opiate analgesics right now is with a backdrop of a current epidemic in the United States of opiate abuse and overdose, and which have led to a number of deaths associated with opiate overdose. Governmental regulations, both at the federal and state level, have been implemented and are getting tighter in regards to the prescribing of the opiates. And that, along with the somewhat that, along with the combination of an inconsistent efficacy in Derkham's disease, brings their use in treating the pain associated with Derkham's into some question. Now, before I get to this next class of drugs, the anticonvulsants and the antidepressants, let me just set the stage a little bit here by mentioning what's called central nervous system sensitization. One of the things that can happen when there's this chronic activation of the nociceptors is it results in an alteration in the central neural processing of pain. The end result being that the brain can actually become accustomed to processing pain and hyper-responsive to painful stimuli. So the brain actually gets used to creating the perception of pain. Now, the anti-inflammatory drugs, they're incapable of modulating pain signal transmission in a sensitized central nervous system. However, the centrally acting antidepressants and anticonvulsants, they can modulate central nervous system biochemistry. And that's where they become efficacious in treating neuropathic pain, because in neuropathic pain, central processing is a critical element, and that's where neuropathic pain is where these drugs are most commonly used. Now, I'd mentioned the modulation of the brain, neuromodulation using drugs. Well, there's another way to perform or accomplish neuromodulation for the treatment of chronic pain, and that's by the application of focused ultrasound, particularly transcranial magnetic resonance guided focused ultrasound or magnetic resonance thermometry guided. This is investigational technology, but it holds promise for the treatment of chronic pain. And what it does is it reversibly decreases the functionality of the neurons that are targeted and temporarily blocks the neural signals from at the locations in the brain which are targeted. And in the case of treating chronic pain with using transcranial MRI-guided focused ultrasound, the ventral caudal nucleus is one neuroanatomic location which holds potential for modulation in treating chronic pain. This is an image of a transcranial magnetic resonance guided focused ultrasound equipment. And this is existing technology. Its use in treating chronic pain is investigational, however, but there are applications for transcranial MRI-guided focused ultrasound, which are currently FDA approved, and in use, the treatment of essential tremor is probably the most widely used, otherwise known as Neurovive. But you see the 3T MRI again, and there's the table, except not in this case, we're not talking about the application to the body, but transcranially using the head module there. Now I want to finish up with talking about two types of drugs. One's low-dose naltrexone, and the other intravenous lidocaine. Naltrexone is currently indicated for treatment of opiate abuse and alcohol dependence. In the currently available form at a retail pharmacy, it would come in a 50 milligram tablet. However, its use as a medication in treating chronic pain is at a much lower dose, so usually in the range of 1.5 to 4.5 milligrams once a day, usually taken at bedtime. The most common dose is being 4.5 milligrams per day. It is off, because of its existing indications, its use in treating chronic pain is considered off-label. It's actually an anti-inflammatory drug. It's been shown to be efficacious in treating pain and fibromyalgia, Crohn's disease, multiple sclerosis, and complex regional pain syndrome, which is the new term for reflex sympathetic dystrophy, or RSD. In fibromyalgia, it's been shown to decrease the plasma concentrations of the pro-inflammatory cytokines of interleukin-6, interleukin-1 beta, and tumor necrosis factor alpha, which we know can produce nociception and allodynia. Low-dose naltrexone has naltrexone in general has two mechanisms of action. It antagonizes both non-opiate and opiate receptors. And it's that non-opiate receptor antagonism by which it exerts its anti-inflammatory analgesic effects. In particular, it antagonizes what are called the non-opiate toll-like receptor 4, which are found on the microglia in the brain. Now, microglia in the brain are macrophages in the brain. It's just a different term for the same cell. Now, what TLR4 does is it activates those microglia or the macrophages. Well, by antagonizing TLR4, low-dose naltrexone prevents the microglia from becoming activated. It doesn't deactivate the macrophage, it prevents it from becoming activated. And it's the activated microglia in the brain that produce the inflammatory and excitatory factors that then cause cause pain sensitivity. And Derkham's disease may actually involve a chronic activation of the microglia. Advantages of low-dose naltrexone: it's low cost, it's generic, there's low side effects with it, it doesn't require any laboratory monitoring, and there's no known abuse potential associated with it. Biggest disadvantage is it is off-label. It's not recognized by insurance company. Your insurance company pharmacy benefit's not going to pay for this, most likely. In order to get it, you're probably not going to find it at a local retail pharmacy either in this dosage. Prescribing it would need to be done through a compounding pharmacy. Which brings us to intravenous lidocaine. This is another promising approach in the treatment of chronic pain. It's given as a low-dose infusion, usually about 5 milligrams per kilogram per day, 5 milligrams per kilogram is a slow infusion, and it too has been shown to provide pain relief. What's interesting about intravenous lidocaine, and this surprisingly, it actually has more potent anti-inflammatory properties than do the non-steroidal anti-inflammatories or steroids like prednisone. One of the ways it works is by reducing the circulating inflammatory cytokines. It's relatively easily administered, it's inexpensive, and it's used safely with few side effects. It's been studied in fibromyalgia, not fibromyalgia, but diabetic neuropathy, where it was shown to provide pain relief for anywhere from 14 to 28 days. This has also been studied in fibromyalgia and Derkham's disease. It was shown in one study of fibromyalgia to provide sustained pain relief for 30 days. In studies in the clinic using this in Derkham's disease, pain relief was provided from anywhere from up to 2 to 12 months after each infusion. There were a couple of patients treated with intravenous lidocaine who had Derkham's disease, and the pain relief in those instances was immediate, and the pain relief can last up to several months. Where intravenous lidocaine may be most valuable is in treating conditions where the pain can be refractory and difficult to treat, such as fibromyalgia and Derkham's disease. This pretty much wraps things up. You may have noticed as I've gone through here that many of the strategies that I've mentioned are all what you might consider to be non-traditional approaches to treating chronic pain. And the reason for that is because treating the pain in Derkham's disease can be extremely challenging and difficult, not only for the patient, but also for the provider. And all too often, the pain in Derkham's disease does not respond well to the more traditional methods of treating chronic pain. Therefore, it can often become necessary to resort to some of these non-traditional approaches. Thank you.
We have time for a handful of questions, and we've had some come in.
Oh, okay.
Okay.
Well, fire away. I'll try. Right. There's no guarantees associated with this. I will give you your money back, okay?
What is misoprostol, and is it over-the-counter or prescription?
Okay, misoprostol, no, it's not over-the-counter. It is a prescription drug. It actually has multiple uses. And I'd mentioned that using it can be an abortifacient. One of the things it's used is in labor to ripen the cervix. One of the other effects, like I mentioned, is it provides upper gastrointestinal protection to protect basically the stomach and the duodenum from the development of, say, peptic ulcer disease and upper gastrointestinal bleeding. It mitigates that.
How long does the pain relief last after transcranial stimulation, and are there any human studies?
Excellent question. Well, as to the first, we don't know, because there have not been any clinical trials yet, human clinical trials on the use of transcranial MRI-guided focused ultrasound in the treatment of chronic pain. It's an early investigational application of this technology. And what was the other?
Are there any human
how long
studies?
does it last? Well, no, there currently are not any human clinical trials. Let me add just for a moment, if you're interested in learning more about focused ultrasound, I would suggest that you go to the following website if you want to write this down. It's www.foundation, all in one word, .org. That's the website for the Focused Ultrasound Foundation, and you can find a lot of information there about this technology. As far as how long the pain lasts, we don't know, because there's not been enough studies done of it yet, or any clinical trials yet to know to have the answer to that.
Okay. If I took naltrexone, I'm probably butchering the pronunciation of that, could I discontinue Celebrex for arthritis?
I don't see why that would be necessary. It's like I mentioned, it's a safe drug. There's no interaction there. Now, I will say this in regards to naltrexone: when it cannot be used is if the patient's already being treated with opiate medications. So if it's going to be used in the treatment of chronic pain and the patient's also on opiates, the opiates would need to be discontinued first.
Okay. And our last question, can low-dose naltrexone, I'm totally butchering this, be taken along with opioids since it is prescribed for opioid addiction?
No. Because the reason being, because it's an opiate antagonist. So it would antagonize the effect of the opiate and could theoretically put the patient into, have them and induce opiate withdrawal symptoms.
All right. Well, thank you so much, Dr. Pulsipher. We
Thank
really
you.
enjoyed it.
You bet.